Great to be here. I think I can say I've been almost from one end of Nebraska to the other this week. And very nice. Can everybody hear me okay? So what we're going to talk about today is, in one sense, quite simple. What happens to the fetus when it's exposed to alcohol during pregnancy? And what developmental consequences does that have over the lifespan? So today we're going to talk about these particular topics. FASD is really common. Most cases are undiagnosed. And this is going to be 95, 98, 99% of cases. So when you're done here, you go to work tomorrow. If you think you're seeing a lot of FASD, that's right, you are. It's familial. There are often many children in the family. It's generational. There's quite a few people in these extended families. It gets worse over time. Diagnosis makes a big difference. Treatment matters. And I think it's obvious that it's preventable. This is not a new topic. In the 1890s, 1900s, in Scotland and England, a series of physicians over there had worked out problems associated with drinking during pregnancy, and they were mostly interested in studying mortality. And they produced a series of studies showing that mortality risk increased from the oldest child to the youngest. So the youngest children died at much higher rates than the older children. And they concluded from that alcoholism gets worse over time, which I think is correct. Another very important observation they had was that many of these deaths occurred on weekends and holidays, and we find that today, but a very weak relationship, but nonetheless it's there. And I think it's pretty obvious that most drinking is done on Friday night and Saturday night, and so the effects are still present on Sunday morning. So it's not unexpected. This is from a series of posters from the Anti-Saloon League distributed in the 1890s and early 1900s. And they have 10 or 15 of these, and every one of them has data about the topics that we're most interested in today. So really what I think happened is that this came up as a problem, disappeared for about 80 years, and then we rediscovered it. When a woman drinks, alcohol moves from her stomach into her bloodstream, crosses the placenta into the fetus. Early in pregnancy, the mom, the fetus, and the amniotic fluid all have the same amount of alcohol. So if the mom's passed out on the bed intoxicated, then the fetus has the same amount of alcohol, and very importantly, the amniotic fluid has the same amount of alcohol. So you can see here, and this varies from person to person, but she starts drinking, reaches a peak blood alcohol concentration, and then it takes a long time to get all this alcohol metabolized. So if she's drinking 12, 14 beers at a time, she's going to have alcohol present in her bloodstream for about 24 hours. If she's a pretty good drinker and she's drinking 24, 30, 36 beers in an evening, she'll have alcohol present for 30 some hours, and when she starts drinking again on Saturday night, her blood alcohol concentration will still not have reached zero. So very heavy drinkers really have alcohol exposure from when they take their first sip on Friday until maybe 3, 4 o'clock in the afternoon Monday. So quite a lengthy period of exposure. Now, an interesting thing happens about 20 weeks of pregnancy. And normally such a minute physiologic detail wouldn't be important, but I think it's very important for people to understand how this works. So early in pregnancy, alcohol comes from the mom across the placenta, down the umbilical cord, and then it just goes back and forth across the fetus. And the fetus breathes out some goes out through the nose. When they urinate, which is where most of the amniotic fluid comes from, alcohol comes out there. And then as the alcohol starts going down in the mom, it moves back across the fetal skin into circulation, and the mom metabolizes it. The fetus doesn't really metabolize alcohol to any significant extent. At 20 weeks of pregnancy, the fetal skin becomes impervious. So water, alcohol, other substances do not cross into the fetus and do not cross from the fetus into the amniotic fluid. So at 30 weeks, or whenever after 20 weeks, mom drinks, alcohol crosses the placenta, comes into the fetus, fetus breathes some out, some comes out through the nose, most of it comes out in urine. It gets into the amniotic fluid and is trapped there for a long period of time, because the only way out of there is for the fetus to swallow it and then back up the umbilical cord across the placenta. So drinking in the last half of pregnancy greatly extends the duration of exposure. So that's a very good reason to talk with women about the fact that it's never too late to quit and it's never too late to cut down. Prenatal alcohol exposure is like a good weather forecast, and it predicts some things with pretty significant reliability. The first among those is that during pregnancy, it's strongly associated with smoking, other drug use, late and infrequent prenatal care, depression, and poor nutrition. So women who are drinking during pregnancy are at high risk for these problems. Women who are drinking around the time of labor and delivery have a 4 to 6-fold increased risk for stillbirth, a 4 to 6-fold increased risk for prematurity. I was worried sick he was going to come up here and correct me for something I said that was wrong. The stress of it almost got me. Is that better? No. I'll just keep talking loud.
It should work. You need to talk to it.
I'm talking to it. How's that?
Better? No.
No. Okay. So a 4 to 6-fold increased risk in stillbirth, prematurity, high rates of birth defects, and a very high rate of hospitalization because of difficult to treat infectious illness. So drinking during pregnancy interferes with the immune system development of the fetus. These children are born, and quite a few of them spend fairly long periods of time in the neonatal intensive care unit for infectious problems, failure to thrive, developmental problems that are in large part attributable to prenatal alcohol exposure. Postnatally, I think it makes sense, right? If they're drinking before pregnancy, they're drinking during pregnancy, they're drinking at labor and delivery, that they're going to keep drinking after pregnancy. So these children live in homes with people who have substance abuse problems, high rates of abuse, neglect, complicated care because of birth defects, the poor nutrition continues, they're exposed to secondhand smoke, the effects of prenatal substance abuse, violence, depression, and a 4 to 6-fold increase in sudden infant death syndrome. So one of the points that I'd like to leave you with today is that prenatal alcohol exposure, fetal alcohol syndrome, are strong risk factors for mortality. A lot of people die from these problems. Here's a mom, and it took us quite a while to recognize something that's really obvious in retrospect. When she drinks, she exposes herself, the fetus, and the fetal germline. So when she takes a drink, she's exposing 3 generations at the same time. So right now, what we're doing is we're getting a developmental and exposure history based primarily on what she drinks. We really don't have a way to look back in time and find out what the grandmother drank that the mother was exposed to, and look back another generation and find out. So this is complicated because in the last few years, we have now found that, there we go. Now I'm going to have to throttle this back a little bit. That there are some exposures that change the genetic code that you have. And they, in essence, leave a mark on your DNA. They don't alter the DNA itself, but they leave a mark on it, which is heritable across generations. And the first research of this came from people who were exposed to famine. So we now know that stress, famine, very likely alcohol in humans. We have good data for alcohol causing these epigenetic imprints, epigenetic modifications in animals, and we're just now waiting for some of these large studies to finish up so we can demonstrate that alcohol has this effect in humans. So many of these very stressful events of pregnancy, early infancy, and childhood change you in ways that are really not reversible. They, by and large, change the heritability of these conditions. Now, I think this is going to be very helpful. This is all data from North Dakota. There's not a single case in here that's not from North Dakota. So to the extent that Nebraska and North Dakota are similar, then this data will be helpful. To the extent that you're different, so you don't play that much ice hockey here or more football, it might be colder in North Dakota than it is here in Nebraska, but otherwise maybe some of these things are the same. So here are the dads. You can see they tend to be a little older. They're unmarried, been out, have substance abuse problems for a long time. Men drinking before and during pregnancy increase the number of terminations of pregnancy. This is associated with fewer prenatal visits, more prenatal complications, and a decrease in birth weight. Now, I think we were the first people to report this decrease in birth weight. It turns out that men drinking during pregnancy decrease birth weight about the same amount as women who smoke during pregnancy. Here's the moms, and I won't just repeat all this data. Just a couple things I want to point out. They tend to have few prenatal visits, and these are late. So if you're a prenatal care provider and you think you're going to build a relationship with this woman before you start talking about this, big mistake. You need to hit this a lick the first time they're in the office. They have a very high mortality rate. If you have a child with fetal alcohol spectrum disorder, you can expect about 5% of these moms to die. And this is a disease that's killing young women in the prime of their life. In fact, if you look at how frequently they die, they're 44 times more likely to die than women who don't have a child with fetal alcohol spectrum disorder. I guess I could summarize this by saying that this is a much more robust cause of mortality than breast cancer, diabetes, or some of the other problems that affect women in this age group. So it makes sense to me that when we find these moms, we want to expend some effort trying to care for them, because getting upset about their disease is not helpful. And for those of you who haven't experienced this, one of the magical things about substance abuse is that early on, the manifestations of the disease are, when you bring it up, I get angry. I get upset. I'm hostile. I deny it. And when you think about it, that just makes sense, right? That allows them to continue to drink, not to accept responsibility. and it discourages people from talking with them about it. So when you're working with these women, you want to know ahead of time that when you bring this up, a significant number of them are going to get upset. They're going to deny this. They're going to vent a little hostility in your direction. And if you have a personality where this upsets you, then this maybe isn't the right kind of work for you to do. I always like to explain to students that about a third of the students that come to work with us have to change because they just don't have the personality. When somebody throws a few books on the floor in my office and pushes a chair around and calls them some names, they get upset, and if they stay upset for a while, then they should probably find something a little less stressful and confrontational to do, because this isn't the right work. Here's the children. We know a lot about the children, and I think this is going to be pretty universal across states, all kinds of groups. Average age of diagnosis, still 7. Many of them come from large SIB ships. Birth weight, they weigh about 700 grams less than kids in our state, matched on a whole bunch of factors. Birth defects rates high, cerebral palsy about 6%, intellectual disability about 40%. In our state, 75% of them have ADHD. Almost all of them are placed out of home, a testimonial to the severity of the alcoholism, that these kids have to be removed from the home for safety and have care. About 15% have a head injury. And how do they get a head injury? They get it the old-fashioned way, right? You're crying and won't quit. Somebody kicks you in the head in the middle of the night to get you to stop. Some guy's drunk, throws you up against a wall or down the steps. Somebody puts a pillow over your face. I have a very good videotape of a mom explaining to us that her child with fetal alcohol syndrome, when he was about 4 months old, fell down the steps. And so we let her talk for a while, and then we say, well, exactly how did that happen? And she's quick to say, well, I don't know, I wasn't really there, but I know he fell down the steps. And he's done it before. He fell down the steps about 2 months of age or so. And so we would explain, well, you know, they don't crawl, they don't really, not really mobile at that age. And it turns out that this child was resuscitated in their home 4 separate times. The ambulance showed up, child was not breathing, they resuscitated this kid 4 times in her house. And it was still about 3 years after that before a social worker showed up at her house to do a safety check and said, okay, everybody's out of here. So that child had a long period of severe abuse, many episodes of head trauma. So about 1 out of 6 of these kids have head injury. Mortality rates are very high. You can see here that 9% have 1 dead sibling, about 5% have 3 or more dead siblings. I put down here some data about mortality rates, rates of complications and stuff. So this sort of summarizes the FASD family, and I think is going to be really helpful for those of you that are thinking about this, trying to orient some system of detection or service provision for them. Where do we find women who drink? Well, I think 100% of people in substance abuse treatment program have substance abuse problems. Almost everybody who uses drugs also drinks. Not all drinkers use drugs, but almost all drug users drink. And the longer you've been using drugs, the more likely it is you're going to drink. In corrections, almost all women in corrections facilities are there because of substance problems, substance abuse, drug trafficking, other problems. Typically, in the first trimester of pregnancy, about 20% of women are drinking. Somewhere around 3 or 4 or 2% continue to drink all the way through the third trimester. Children in foster care, so let me just stop and get us zeroed in on this. There are a few kids in foster care who are not there because of parental substance abuse. So that might be 1 in 10, something like that. So children who are in foster care, almost by definition, have been exposed to alcohol and other substances. So if you're taking a very high-risk population like that, and you're skeptical about whether or not they've been exposed, that would be the equivalent of going to a substance abuse treatment program for women and saying, well, I'm not sure all of you guys really drank. You might be exaggerating this. That is sort of nonsensical. So some of these places, the rates are so high that just by the fact that they're present in those settings almost certainly assures you that they have had exposure. Foster care is one of those. So if you want to detect a lot of kids who've had exposure, let me offer you a suggestion, easy to implement. Screen children of women going into substance abuse treatment. Screen children going into foster care. 2 extraordinarily high-risk populations. A lot of times we don't have an opportunity to view the mom. She's dead, she's missing, she's in correction somewhere, we can't find her. So we developed this little tool here, this maternal risk score, so you can calculate a likelihood, really, that she had prenatal alcohol exposure. And we use this when we don't have a history. So if you're adopted, your mom's dead, your family's in Washington, and you're in foster care in North Dakota. So it's a really quite helpful little tool for that. How about a little Nebraska data? So I have an epidemiologic calculator online, and this uses fixed variables. So we routinely calculate this data for every state in the United States. So here's what I think for Nebraska. 10,400 women using alcohol in 2013. How many are identified? I'd be amazed if 1,000 or probably even 500 are identified. Heavy users who drink all 40 weeks of pregnancy. This is women who've been drinking all through pregnancy and are going to drink in the week before they deliver, 520. Typically in most states, somewhere around 5 or 10 of them would be identified. So almost all of these guys are missed. Now, I'm going to spend just a minute on the diagnostic criteria. So before I do this, I want to get us oriented in the right direction. We should not be primarily interested in fetal alcohol syndrome. We should be primarily interested in the common manifestation, which is called alcohol-related neurodevelopmental disorder, what we used to call fetal alcohol effect. The problem with fetal alcohol effect was as soon as somebody heard it, they knew what it meant, so we had to change it. And we came up with this clever little idea called alcohol-related neurodevelopmental disorder. Nobody's sure what that really means, so it's a fantastic term to use. So fetal alcohol syndrome is one of the diagnostic categories of fetal alcohol spectrum disorders. So we got this little tent in here. We got fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorders, and birth defects. Okay, so this accounts for 10, at the most 15% of cases in prevalence studies. So 85% of the affected people do not have this. This is really crucial because all kinds of clinics and settings are hung up and they can't act because kids don't have the facial features. The facial features are uncommon. They should not be the focus of our efforts. So, fetal alcohol syndrome, you have evidence of brain damage, abnormal facial features. I'll show you what these look like in a little bit. Growth impairment, height, weight, often head circumference. Partial fetal alcohol syndrome is just a less complete version of this. And alcohol-related neurodevelopmental disorder. You don't need facial features. You don't need growth impairment. You need evidence of brain damage. Prevalent studies show that about 1% of children with fetal alcohol, 1% of children have fetal alcohol spectrum disorder. You can see here that we did a study. We screened everybody going into kindergarten for 19 consecutive years, and we found that in this site it was about 2%. I think 1% is typically a pretty good number for the number of people that have fetal alcohol spectrum disorder. This summarizes some of these prevalent studies in North Dakota. Here's one in a very high-risk community where one baby out of 17 had a fetal alcohol spectrum disorder. This is a pretty impressive societal burden for any community to take on. I've been to a couple of places in Australia where it was very high. It's very high in South Africa. We have a big research site in the Congo, and the rates there are very, very high. Just as a note, we did screening in our what at that time was called EPSDT, Early Periodic Screening Diagnostic Testing Program. Most states have renamed this thing. It was exactly 1% of the children going in there. So I think in Nebraska you have about 260 new cases every year. I don't know how many of these are diagnosed. If somebody said 10%, I would maybe reluctantly agree. I think it would probably be closer to 10, 12 new cases a year get diagnosed, and it takes 8 or 10 years to do that. So in your state, you have thousands of undiagnosed children. Thousands. And they're in special education, early intervention programs, developmental disabilities, foster care, juvenile correction system, and mental health facilities. And there are thousands of them in Nebraska. Almost all undiagnosed. Let's just have a look and see what that might actually mean to us. Just looking at foster care here. So about 3,400 children in foster care in Nebraska. If the prevalence rate in foster care is the same as it is everywhere else, 1%, that would mean you have 34 cases. Now, if you looked at the foster care registry and you actually had 34 cases of FASD on there, that would be impressive. If it was 10%, that would mean there's 346 cases in foster care. If it's 20%, 690 cases. And I think 20% is a very low estimate for foster care. And as I've said in all these talks, I will buy the person a cheeseburger at any place of their choosing if they can bring me some data showing that you have a doctor in Nebraska with 200 diagnosed cases, or that one of these systems of care has 10% of the cases diagnosed, because it's just not likely. And this is true in every state in the United States. everywhere you go. Nebraska, no worse off than anybody else. 4,000 kids in some version of your juvenile correction systems. So if it's 10%, 403 cases there. Cheeseburger offer still good if you could produce some data showing to me you had 25 diagnosed cases. Adult corrections, if it's 10%, 479 people, 20%, 900. So you can see that there are, to just emphasize this point again, thousands of undiagnosed people. Now I bring that up because it's really important for you tomorrow. If you go to work tomorrow and you say, there's something wrong with me because I'm seeing FASD everywhere I look. You should be. You should be. If you have anything to do with foster care, anything to do with juvenile corrections, special education, developmental disabilities, a birth defects clinic, the adult corrections population, children of women who are in substance abuse treatment, you should be seeing lots and lots of people with FASD. Lots. So I want to just sort of prop up your courage in case this happens and you decide you want to do something about it. Is this costly? It depends. It's costing you about $109,000 a day, $49 million a year. So in Nebraska, I don't know if that's big money or not. North Dakota, we'd like to have that money for something else. About $9.5 million spent in special education and juvenile correction systems. And actually, if we come to this, we have a nice lunch, we go home, we don't do anything about this. We get back together in 5 years for an update on fetal alcohol spectrum disorders. You'll have spent about $200 million on this problem. So money is not the problem. You got all the money you can need. $109,000 a day, a lot of money. The problem is getting that money unhooked from the current systems which care for people who are unidentified, getting some of it reattached to identification of people and some prevention. That's where you need. And just to hit this once more, if you want identification, pick the low-hanging fruit first. Screen children of women in substance abuse treatment, screen in foster care, and screen in juvenile corrections. That is the low-hanging fruit. I want to hit my disclaimer once more and then I'll get off of this. Kids like this are 10 or 15% of the problem. This is an atypical person with FASD, not typical. Most kids don't have all these facial features and growth impairments. So this little girl comes into the office. At a glance, you can see she's short and skinny. She has a small head. She's in foster care and has developmental delays. She has a thin upper lip. Under her nose there should be two little ridges called the Fetal ridges, and you can see that's smooth across there. Those ridges aren't there. We measure from the inner corner of the eye to the outer corner of the eye. It's small. Why is that small? Because the eye and the brain come from the same embryonic tissue. Alcohol causes cell loss, and so you end up with a small eye and a small brain in these kids. Now, there are other features here, but they're relatively much less important. So here's what she looks like. Remember, short, skinny child, in foster care, abnormal facial features, developmentally delayed. That is fetal alcohol syndrome. So it doesn't take a $40,000 evaluation to sort this out. And what we need in all states, including Nebraska, is more medical professionals to step up to the plate and start taking a swing at this. And the key groups are not geneticists and not dysmorphologists. The key people are psychiatrists, neurologists, and pediatricians. So you have to focus a lot of effort on psychiatry, neurology, and pediatrics, because that's where most of these kids are going. And it's where all the adults are going, by the way. So let's look at her a little bit older. Now, you see immediately the problems with the criteria for fetal alcohol syndrome. When people get older, many of these problems attenuate. And you probably are more sophisticated at this than I am, but this girl is somebody I would walk right by in a high school cafeteria and never give a thought to her having fetal alcohol syndrome. I wouldn't even miss a step. So as she's grown older, the height and weight problems have disappeared. Her facial features have attenuated. However, something's gotten worse. Her behavior problems, mental health problems, much worse. Ideally, you would diagnose this girl, you would call up somebody who would go track down the mom and get her into treatment. That didn't happen. So the next patient we saw was this girl. Much smaller head, much more distinctive facial features, much greater developmental delays, and congenital heart defects. This is the previous girl's younger sister. She has a little ptosis. You can see both eyes don't open all the way up, but she is much more severely affected than her sister. Here's what she looks like a little bit later. And this is a fairly typical presentation of fetal alcohol syndrome. IQ, I can't really recall, I think in the 50s. Small eyes, upturned nose, filtral ridges, pretty indistinct, thin upper lip, short, skinny girl in foster care with a previously diagnosed sibling. Younger kids are at huge risk in these SIBShips. So if you have a sibling anywhere, if you have any child in a family who's diagnosed, all the kids need to be evaluated, every one of them. And you can just imagine the burden that you have if you're identifying 1 or 2 or 3 of these kids a week. You got somebody trying to find the mom, and you're trying to figure out how to get the rest of the kids in for evaluation. But if you don't do this, the outcome is going to be poor. These are women who tend to have lots of kids, and we have an opportunity to prevent exposure in subsequent pregnancies by identifying these kids as young as possible. Here's what she looks like a little older. The ptosis on one, if you look, you just draw an imaginary line, you can see that one side of her face different than the other side of her face. She has more ptosis here on the right than she does on the left. But the main problems with her, she's not having problems because of a relatively thin upper lip or a missing philtrum. She's having problems because of low IQ, mental health problems, and congenital heart defects. Those things aren't going away. They're going to be with us for a long time. So in her case, we can wish she would get over all this stuff. We could get mad because she doesn't learn fast, because she has behavior problems, because she needs medication for her heart. But neither one of those are going to help. So what we have to do with her and with people, all people who have fetal alcohol spectrum disorder, is to realize that they have a lifelong impairment. We can make this much better, but in most cases we cannot get rid of it. So I was in Lexington having lunch with the people who attended the conference. And there was a guardian ad litem there, and he was sharing with me his philosophy on life and stuff. And He said, well, you know, over the past few years, I've started getting a little tougher on these people. He said, these women that don't even care enough to show up for these meetings about their kids, he said, that's just not right. And he had a couple other things. And so I got to thinking about this, and I thought, if we looked at that woman and we followed her over the lifespan, I wonder if it wouldn't look like this. Around 2, she was messy, disorganized. She'd be the one that was always missing a shoe. At 4 or 6, she'd go outside, come in with one glove, couldn't find her coat, losing stuff, had stuff strung all over the house. At 6, go to school, forget her books, come home without her homework. At 10, go to school, bring home the homework but not the books, or the books and not the homework. Do some of the stuff, forget to hand it in at school, lose stuff in her locker, couldn't find her sweater, couldn't find her jacket, late for class, poorly organized, can't show up on time. As an adolescent, the same thing. And here at 22 years of age, somebody says, look, you show up on time for these meetings. And when you think about it, isn't that kind of ridiculous? That an impairment she's had for 20 years, we're just all of a sudden going to pretend isn't there, and that she's personally responsible for this. Kind of like telling a guy like me, put those glasses down, man up, and do without them. Or if I'm wearing a hearing aid, say, put that thing back in the box. If you really cared, you wouldn't need it. My favorite example would be if I had a neighbor who had one leg. So I go to the bank and I get some $50 bills and I say, Fred, today I'm going to teach you to walk on the leg you don't have. Step out here in the driveway. So I hold $50 up in front of Fred. I say, hop on the leg you don't have, Fred. Down he goes. I pick him up. I say, okay, now suck it up, let's hit it hard. Hop on the leg you don't have. Down he goes. After a while, I would conclude 2 things. Money is not a good motivator for Fred. And second, Fred doesn't care. So when you see these people as adults, let me just stress this because it just raises my blood pressure. If the meeting's important, let's have one of the people with the nice clothes and the car and the good job and the health insurance and the retirement package get off of their rear and go pick that woman up and bring her there. Don't go to a meeting and complain about somebody having the same problem now they've had for 20 years. It makes you look dumb. Don't do it. Somebody needs to go get her. Preferably, leave early. Go pick her up. Swing by McDonald's and get her an Egg McMuffin and a cup of coffee. When you come into the meeting, sit down beside her so that she feels like she's a part of this. Many of these women come in the door, all these nicely dressed people sitting in one place, they're sitting over here by themselves. When they walk in the door, the first thing they're thinking is, what was I thinking of coming to this? The second thing that happens at these meetings is that among all of these professional people, there's somebody there who's just bursting, I mean literally bursting with advice. So they'll start off the meeting. Mary, now you know we're here to help you, don't you? That's why we're sitting on this side of the table and you're over there. We're here to help you. But you have got to help yourself. This is the 3rd time we've scheduled this meeting. Now, we have cars and you don't, but that has little to do with this. Our heat's on and yours isn't. That's not important. We don't have alcoholism and you do. We don't care about that either. You've got to help yourself and show up at these meetings on time. So, I want to offer you some free advice. Schedule the meeting and don't let that person come. Have somebody in authority call them aside and say, don't come. because you're killing your communication with this person. You're destroying it. You don't want them there. They don't offer, can't add anything that's going to help you. They're killing you. Don't have them. And I couldn't tell you how many meetings I've been to. You can just see it. It's like, the cork is going to pop right out of there. There's so much tension and pressure there for them to share their wisdom with you. So let me summarize this. Get up early and go get this woman. Buy her some coffee. And if you don't complain about her not being there. If it's important enough to get 7 or 8 people with a good job, health insurance, a car, who don't have alcoholism and have health insurance with the heat on in their house, let's not be dinging somebody who can't get there. Because it could well be they just don't want to come, they made a bad choice. But a lot of the times, they can't get there. We don't need to add to their stress. Let's help them. Let's help them. You're going to make me blush. Quit that. So here's another look at Nebraska. 260 new cases every year. Just think of this. 260 new cases every year. What is that, 5 a week? Something like that? 1 Monday, 1 Tuesday, 1 Wednesday, 1 Thursday, 1 Friday. Going to have a new one today. 51 of these are going to be born into a family, a biologic family, where there's already an affected person. 15 or 16 of them are going to be born in a family where there's multiple affected children, undiagnosed. This is a failure of our public health prevention system. This is a failure of primary care in our hospitals and clinics. And it's costing you a bundle of money. Here's what this looks like. You can see here's a family. And I just use this to show how we collect this data. All these folks in here have one of these problems down here. So you can see that in this study, we had multiple families. Stillbirth, the risk was increased 4-fold. SIDS, 10-fold. I think that might be a little peculiarity to North Dakota, but I don't think it's going to go below 6-fold as a SIDS risk factor. Infectious illness, deaths from infectious illness increased 10-fold, and these are typically very young children, little kids. Oops, let me just back up here. One other thing I'd tell you is that risk from the oldest siblings to the youngest siblings is increased 4-fold. So younger children, much higher risk. Are there questions about that before I go on? My wife doesn't like coming to meetings with me. She said it's just too depressing. So to summarize where we're at now, I think you have in Nebraska 260 new cases of FASD a year. You have lots and lots and lots of people who are undiagnosed in all these systems of care. Part of that's because you need to increase your screening strategies at key gates: foster care, women and substance abuse treatment program, juvenile corrections. The diagnostic capacity you need is not more geneticists and more dysmorphologists. That is not going to solve the problem. That's part of the problem already. What you need is more psychiatrists, neurologists, pediatricians, psychologists trained to do this, strung out across the state. So I've provided for you in your packet some screening tools. One, a maternal risk score. There's a fetal alcohol syndrome screening tool, an alcohol-related neurodevelopmental disorders screening tool. We have 3 or 4 others, but I've provided these for you, and they're in that little booklet called FASD and Corrections or something like that. There's a little pink card if you didn't get that. That's the Ideal Prenatal Care Screening Program. It asks one question: when was your last drink? And you can see how it's used, and then on the inside is some additional data. So it can't get simpler than one question: when was your last drink? So hospitals and clinics actually save time and money if they do the screening using this tool as compared to others. And these are published and validated, and I don't think there's a need to get into all that. I'm going to start down this management thing a little bit and do a couple slides, and I'm going to stop and turn this over to Billy for a little bit because I don't want you all going to sleep while I'm talking. So what would we do from the standpoint of FASD management? Number one thing, and I think this is pretty straightforward, common sense stuff, the stuff that family practice doctors, pediatricians really emphasize is prevention. And in our case, we want to prevent abuse and neglect. We don't need to have kids exposed to a lot of abuse or neglect because it presents lifelong problems that kids don't recover from. We can wish that when Billy was held down by his drunk uncle and had sex forced on him, he'd get over it. And that this anger and hostility he has would go away. We can wish that. We can get mad because it doesn't. And we can blame him for it. But he's got an awful tough problem there. Awful tough problem. We can carefully avoid multiple foster homes. So I got to run you through this so you got some idea how this works. Because I think most of us don't have a clear view of this. So we take our 8-year-old, and he's heading out the door, and Mom's sitting there knocking back her first iced tea glass full of vodka for the day, and he had some Fruit Loops, and he's heading out the door, and she said, "Stay on the sidewalk, don't talk to strangers," because he's walking to school. He gets to school, runs around on the playground, sitting in math class trying to figure out what could be the practical value of carrying and borrowing, and why anybody would want to do math that is that difficult. And over the loudspeaker you hear, "Larry Burd, come down to the principal's office. Larry Burd, report to the principal's office." Now, it's clear to him, right, that if you got difficulty, who are the go-to people for you? Well, you find a police officer. If you're at school, you get hold of the teacher or the principal. He walks down to the principal's office, and there's the principal sitting there with this woman. Is she nice or what? She's got nice clothes. She's got that rip snorting jewelry. And she uses some version of, "Larry, things aren't going good at home. We're going to have you move to a new place." And so Larry looks over at the principal thinking, well, he's obviously going to intervene here. And the principal's been kind enough to go to his locker and get his books and stuff, hands it to that woman, and the two of them go out and get in the car. Larry is not stupid. He's watched TV. He knows kidnapping when he sees it. He knows how this could turn out. She gets him in the car, drives him across town, pulls up into a driveway, and says, "Oh, you are going to like Margaret so much. She's so nice." In the two of them go. Some woman comes boiling out of there, shakes hands with him. They chit-chat a few minutes. And the woman who took him from school left him at a strange place. Larry has seen TV. He knows this is bad. It now is clear to him what happened to his little brother and sister when they disappeared. It's crystal to him. He's in there. Pretty soon this woman goes, "Geez, Larry, how about if we get you a little bath?" So upstairs in the bathtub he goes. He's sitting in there and he's thinking, what a day, huh? Fruit Loops for breakfast, walked to school, couldn't do my math. Here I am in a strange woman's house, naked in the bathtub, and it's not even noon. Out of there he comes. She gets him some nice clothes. So Larry had one valuable possession. One thing he cared about. His grandmother had given him a shirt. It was his only reminder of her. He wore that every day. It was disgusting. It was completely worn out, filthy. He wore it every day. Foster mom looked at that, holes in it, too small, dirty, beyond repair, threw it away. She got him a nice new shirt from Walmart, Kmart, somewhere. They're in the house, nothing's happening. Nobody's coming. Later that night, some girl shows up. She looks like the mom, probably related. Later on, some guy shows up. Larry has experience with guys. His mom would go out and get drunk and bring him home. And when she passed out, they would wake up. They were looking for something to do. These guys. They were looking for something to do. And they found him. He has experience with these guys. And he's quite leery of this. You might say Larry's having a little problem with anxiety now. He's a little bit stressed out. He's been kidnapped. He's in the same place his brother and sister were. He hadn't heard from them since they left. And there's nobody coming. Nobody's coming. This guy takes him up, puts him to bed, reads him a story. You cannot do that to children multiple times. Nobody is wired biologically to manage that kind of stress. We do that to kids 5, 6, 7 times, and then somebody says, you know, Larry would go anywhere with anybody. I think he has attachment disorder. If he has attachment disorder, we caused it. So when you're thinking through these foster care placements for these guys, try to look at it from their standpoint and make each one the last one. And in the rare event you do need to move them, get them into some place where the resources are so great that you're not going to have to move them again, because you are really, really injuring them by moving them around. In our clinic, I have a kid that comes to see me. He's been in 31 different placements. Whatever problems the alcohol caused probably aren't as great as this mismanagement by this foster care system he's in. So think about that from the child's viewpoint when you're making these decisions. Now, I'm going to take a little break here. Are there any questions that I could answer before I go on? Yes.
Is there going to be discussion later on about them kind of growing out of some of this? Some of the statistics have said in the past, by the time they hit 35, we should start seeing some of this problems leaving.
Uh-oh.
That are coming from fetal alcohol to abuse with pregnancy.
So what's the future for these guys? Well, here's the future. Fetal alcohol spectrum disorders get much, much worse over the lifespan. 10 This is due to two things: increasing severity of their problems, lack of understanding of the cause of their problems, poor management, and then a huge increase in the number of comorbid conditions as they get older. I'll give you a good example. At 2, you're at no risk for substance abuse. At 16, if you're not thinking about this with this population of kids every day, you got to have a reality check. They got the most severe genetics you can have for substance abuse. Very often in these families, substance abuse killed one of their parents, often several people in the family. It cannot get more severe than these guys have. And if you think you're going to manage genetic risk like that, the way you manage everybody else, that is naive. Fetal alcohol spectrum disorders tend to get much worse over time. We can change that by doing a couple of things. One, we could decrease the excess disability, prevent secondary disabilities. So, for example, don't do 31 foster home placements. Don't do 11, don't do 6, and try to do 1. So there's a lot of things like that we can do. Early diagnosis, better outcome. More services, better outcome. So in our studies, people don't do that much better over time. The reason that they do better in their 30s, Billy, it's your turn, in their 30s and 40s, is that by then people have recognized, I think, that a lot of these problems we're going to live with. And once you see them as impairments and you start accommodating for them, things get a lot better. Once you begin to focus on getting rid of the substance abuse, treating all the problems you can treat, and people get used to dealing with these folks and they know how to do it, things get better. But it's an awful rough road for these little kids, adolescents, and adults until you get there. Should we take a break?
We'll take or I think we have another question over
Yes.
there. If you wait for me, I can
Let's-
bring the microphone.
Okay.
We're recording this as well, so. Because we're going to post it on the website, so it's for the people who watch it later. Oh, okay. Yeah.
One of the things that I was wondering about was, you take a fetal alcohol syndrome child and their brains are they're different because of their fetal alcohol syndrome. There is no way, are you saying there's no way to make them better if they stay in one place, if there is the love and affection of a family, if they are early diagnosed? What is the treatment for these kids?
Well, I think that's a good question. So you have brain injury, brain damage from prenatal alcohol exposure. Some from smoking, some from drugs, some from poor nutrition, some from stress, some from depression. You have some brain damage from abuse and neglect, secondhand smoke, poor nutrition, stress, getting whacked around a little bit. So can you get rid of that by being nice to them or loving them? And probably not. Can you make life better for them? Sure. Because one thing these kids typically are short of is stability, care, and consistency over time. So you can make it better. But if I lose the vision in one eye because somebody kicked me, love is not going to restore that. If I can't hear out of one ear because somebody got mad at me in order to discipline me, great story, had me hold a pet while he shot it while I was holding it, no, you can't love that away. That's not going away. Love and children go together, and they do well. So you can maximize my performance, but I just want to tell you, if I got an IQ of 80 and have memory problems and attention deficit disorder, we've got to know this, understand it, treat and accommodate it. Because if you try to get rid of it, you're just going to get upset with me. Developmentally, some of this stuff will go away, but the trend is to have more and more problems as you get older, not fewer and fewer. So let's take a break here.